Okay, well, hello everyone. Thank you for coming to our March coaching call. We're really excited today to have Adam Maselowitz here from Peer Assistance Services. And he's going to start us off by talking about kind of that middle period after someone's is screened and kind of how you manage that patient and give them the best care. So we're looking at brief interventions, specifically in the setting of the perinatal population. So please help me give a warm welcome to Adam Maselowitz.
Thanks, Elena. I appreciate that. Thank you all. I'm glad to be here. Just a little bit about sort of my background with SBIRT. So I'm an SBIRT practice facilitator, and I basically what that means is working with generally primary care settings up in my sort of area. So I live in Fort Collins, so the Larimer County area, and really partnering with practices, clinics, staff, care teams on the nuts and bolts of what it means to implement SBIRT. So that's a little bit about my background. I've been doing this for about 3-4 years now. And there's a lot I really jive about it and jive with it. And one of those things is really the brief intervention, that conversation, and some of the motivational interviewing skills, for instance, that infuse that conversation. So really like the topic today will be like looking into the nuance of that conversation. That is different in different settings for sure, and absolutely, has different considerations, which I'm sure you all have experienced within an L&D setting as well. So we'll get moving here. Some of our objectives for today. So we're just going to do a brief review of what the brief intervention is within the context of SBIRT, just for those that may need that refresher. And then we're going to go into some practical sort of practice clinical considerations when delivering the BI, specifically more of like a trauma-informed lens. And I'll make sure that you all have some resources and these slides as well, excuse me, after the presentation today. And then we're going to go through just a little case study, which is helpful, to sort of go through a case study and sort of a script almost of how, it might sound, and then really provide some opportunity for you all to ask questions. And just provide like a space for some discussion as well. So again, what is SBIRT? And I think probably most everybody on this call probably has received some type of SBIRT training up to this point. I've been lucky to Peer Assistance Services and the SBIRT in Colorado program to partner with CPCQC on a lot of this work and really have this sort of reciprocal learning, of informing the best practices of SBIRT implementation, but, sort of what that means within an L&D sort of perinatal sort of spectrum. But for those that don't know, it's an acronym. And when we say screening, we're saying using validated screening tools around substance use. And can be dependent on setting and environment. And then based on that validated screening tool, when it's indicated to engage a patient in a brief intervention, which essentially is like a motivational conversation to enhance the patient's considerations for changing around their use behavior. And when warranted, when other indicators sort of line up, that there's a warm handoff or a liaison to maybe more further assessment when it comes to a substance use behavior and or a mental health issue. So essentially, what SBIRT is. This may or may not be familiar to you as well, but this is just, again, a sample workflow. And I don't know, if this is sort of standardized up to this point, as far as those that are participating in the AIMS project. But this, again, is just really more like a visual of what a workflow looks like. And again, with our focus today on brief interventions of just where that falls, right? Ideally, we're universally screening, right, our patients, and universally screening. We're not going to talk about screening so much today, but in its own right, when we universally screen, we sort of set sort of a tone in some ways for just the message of a standardization that we ask everyone these questions. And in some way, both overtly and eroding some stigma around talking around this issue. And then, through this pathway, this again is a very general workflow, but ultimately what we're talking about today is when a positive pre-screen or a positive screen leads to or indicates, okay, it's important to engage the patient in this conversation around risk. So just share that, again, this basic workflow as sort of where we're at. And if so, in this workflow on the very right-hand side, that's sort of what we're talking about today. It's like, again, when the screening tool indicates such that we're engaging with the patient. If you've been through any of our SBIRT in Colorado's SBIRT trainings, you know that we coach on this specific model of the conversation, what's called a brief negotiated interview, which has these steps, right? This raise the subject, provide feedback, enhance motivation, and negotiate a plan and advise. This is an ideal, of course. It's like it's presented in a linear way, but sometimes it doesn't always happen that way. But ideally, we coach on it because there's a lot of evidence around it. It's pretty straightforward and easy. It actually was developed within an emergency department setting, so it can be delivered, within a 3 to 5 minute time span. But again, these are just some steps. And I share this today because what we'll do here in the next few slides is sort of go through these steps just with, again, this sort of idea of a trauma-informed lens, of what the just best practices might be within these steps. And then again, we'll transition into more of like a case study script as well. But when we say raise the subject, we're raising the subject about the screening itself and what are the best practices around that. Providing feedback means, engaging the patient a little bit more on what those screening results are, understanding a little bit more about the context of use, motives for use, clarifying maybe some information that's already been, self-administered as far as on the screening tool. And then, pivoting on some level to providing, after a safe space has been established, to some points of education around perhaps the substances and the use. And then enhancing motivation, which is really, really where the rubber hits the road within the brief intervention of how we do that. Different sort of tactics from things like importance and readiness rulers to how we use reflections and open-ended questions and things like this. And then, based on patient readiness, which is so much part of this, like when we can sort of help establish a plan, and that plan may be, like connecting to a more broad care team, but really sort of coordinating that care. So in a nutshell, that's what these steps are. So what are some of these trauma-informed, sort of, and now that we'll go through some of these steps, and just some, general sort of trauma-informed best practices. What you'll see in front of you is, this is a conversation guide for delivering a trauma-informed brief intervention that comes from the National Council of Behavioral Health. And these, are not necessarily profound, but, worth maybe establishing. And we're sharing this today. I'm sharing this today, within this context, of trauma-informed language, and acknowledging, just the very unique, I think, challenges sometimes within an L&D unit. Already so much stigma around talking around this conversation, probably in the general sort of public, general healthcare settings, but the challenges there within specifically a labor and delivery unit, and the pressures on you all, to navigate that kind of conversation, and the stresses and the constraints that you have on you likely. So I just want to acknowledge that up front, and we'll transition into some of these best practices. So raising the subject, again, this is just raising the subject about a screening that has been administered, and I won't go through all these bullets, but, some things like, being mindful of just how the history of trauma may show up. And so that could be, somatic sort of experiences. You might have experienced that with a patient of just how noise or temperature can sort of accentuate perhaps a trauma response. Of course, being aware of just tone and volume, again, like acknowledging that we all have lots of constraints within our work, but how that can show up, of how we engage in this conversation that already, again, has a lot of stigma associated with it. And, setting realistic expectations and goals for the time together, sometimes being able to communicate up front just what your role is and what your role isn't, and perhaps even like where you fit within a care team and how this sort of conversation fits in the broader spectrum of care can be helpful. And again, I'll make sure that you all have like this guide in a more, again, as a addendum to this presentation today. Provide feedback. So this would be, again, this place where, ideally you've gotten some permission, to talk about that sort of screening result with the patient. And you're in this place of clarifying, understanding a little bit more, and then providing sort of in this place of pivoting and providing some feedback, to the patient. So much of this, of engaging with the patient is listening with this sort of intent to understand. And being able to commit to that sort of listening process and really hearing what those sort of motives are and what's happening within a patient's life. We say, like, there's a lot of often focus on language and what language can mean and trigger in its own right from a trauma-informed place. We have just some examples here you see in the middle of your screen of just some more trauma-informed language. Again, language is a moving target. We're human beings. We can't know all the trauma triggers for our patients, but these would be necessary, like sort of best practices. And really, this focus on, and this may come up, within this part of the conversation, but, overarching, like this sort of strength-based way of focusing on, what are those strengths for the patient? As far as their assets of being able to make decisions in their life to change perhaps their use behavior for them and their baby. Again, pretty general feedback here. Enhanced motivation. So this would be sort of the step where, maybe there is some, some movement on a desire to change, a use behavior. Maybe there isn't. Maybe there's been a lot of pushback up to this point. But this is a place, where it can be helpful to continue to like sort of use, and we'll talk a little just really briefly on sort of like some motivational interviewing sort of skills that can be used throughout this process, like open-ended questions, reflections, and things like this. But really, like I like that middle bullet, utilizing a strengths-oriented approach with open-ended questions. How have you been successful in the past, perhaps? And addressing your cannabis use or the stress associated with that you have cited that is a reason why you use cannabis at this time. What coping skills have you learned from your life experiences up to this point? Again, a very sort of strengths-based, acknowledging that the patient has wisdom of their own, which may be, again, just hard to acknowledge based on multiple sort of conditions within a labor and delivery unit. And then focusing, like, on the very last bullet there, on, tactics or strategies like the readiness ruler, which I'll show you here in a little bit, and you likely are familiar with, but can be really helpful, like really concrete tools to understand a little bit more about what are the motivations or readiness for a patient. So this is just that, these are the, this is something we coach on within our SBIRT basic trainings and our perinatal focus trainings. But using these scales as a way to enhance motivation and just to understand a little bit more about, what are those strengths that the patient possesses. So that could, again, sort of sound like this, like on a scale of 0 to 10, where, and in this example is drinking, where 0 is like, no, I'm not ready to stop drinking at all, and 10 being, I'm really ready to stop drinking. Where would you put yourself on that scale? And let's say the patient says, well, maybe a 4. And we would respond in a way that would say, okay, why not a 0 or a 1, a lower number? And we do that because then we promote change talk and the reasons for change. And then therefore we can better understand perhaps the strengths that the patient possesses in making, some positive changes in their use behavior. So again, just an example here. So again, the trauma-informed sort of BI when it comes to follow-up and planning, let's say that screening has already happened, we engage the patient. Again, these are sort of idyllic steps, in some way. But we're in this sort of place where the patient has like sort of made some movement, some acknowledgement, maybe like has like expressed some desire for change. Important to recognize anything that the patient is willing to do to address. So in this very much like a harm reduction approach, and just being able, the linkages of care, especially postpartum, how important that is for both the mother and the child, is important. So any, even like that, just like, some follow-up or agreement to like talk with an additional sort of part of your care team can be really helpful. And then again, reinforcing just that you're here to help and that this is an ongoing discussion and you're part of like a care team that's here for support for both mom and baby. Again, nothing really profound here, but these are just, it felt like important things to maybe share. I'd mentioned motivational interviewing, and you all may or may not be familiar with MI, but motivational interviewing girds the best practices of the brief intervention. And, I share this because, and for what it's worth, Peer Citizen Services has started to offer some pretty, primer MI trainings in relation to our SBIRT basic training that can be found on our training calendar on our website, but really start to go into a little bit more about these skills, right? And I share these two things because these two things are fundamental to MI. And they ideally, maybe you like, whether you're familiar or not familiar with MI, these are things that maybe resonate on some level with this conversation that you maybe find yourself in and day out. But, I share the spirit of MI because in so much it is the values that are foundational to the interactions that we have. I love MI so much because it's just like, these are like, I feel like skills that we could use in our whole world when it comes to communication, and ones that I try to like use. I mean, I sometimes use open-ended questions and reflections with my children, for instance, but partnership, compassion, evocation, and acceptance, these are the values, the foundations of motivational interviewing. And what does those really mean when it comes to this very like this interaction with our patient? Do we view them as a partner? Do we view and like interact with them and give ourselves compassion within that interaction that can be challenging and hard? Are we in a place to evoke, those strengths, like those desires and need for change, acknowledging barriers, acknowledging, difficulties, and sort of sitting and working alongside the patient on those ways, and accepting where the patient may be at that moment in time. These are all like the fundamental skills or values of motivational interviewing. And how does that translate? They translate into these, again, what are called the ORs, the skills of motivational interviewing: open-ended questions, affirmations, reflections, and summaries. Again, if you want more information, about what these sort of look like, practicing them, because MI is simply something to be practiced over and over again, please do let me know. And we can, whether it's an online training or perhaps something that's maybe more perinatal labor and delivery specific, we can maybe work on that as well. Okay. I think we'll go right into this in this case study, and we'll make sure that there's some time here at the end where we can, if there's any questions, there's any, discussion, we can do that. But this case study is meant to be something, okay, let's go through a sample conversation in some way. You may have, in the Yelp bubble above you, like, well, Adam, do you work in a labor and delivery unit? Do you have any experience? And I don't. And I want to acknowledge that. I am trained on the best practices of this conversation and the implementation generally. You should know, though, that this script, case study that you're about to see, was developed, informed by one of SBIRT in Colorado's consultants, who I admire quite a bit, Carolyn Swenson, who is a nurse by trade and actually has some experience within sort of that perinatal service delivery area as well. So just that's out there. So what I'm going to do is I'm just sort of going to read through this, and there's going to be a patient and a provider sort of script, and I'm going to play both. And then, at the end, we'll just sort of like open it up and just sort of what your feedback is on that. So that's how we'll proceed at this point. Okay, so this is a brief intervention in a labor delivery unit. What we're going to talk about is an opioid use, as far as our, like, what is the substance just as an example. Our patient, this is their second pregnancy. The first child is cared for by a paternal grandmother. There's been inconsistent prenatal care. Tried decreasing oxycodone use after she discovered she was pregnant, but subsequently started using again within a week. That's a misspell. Sorry about that. Has a friend who has been receiving medication-assisted treatment when it came to opioid use. And that friend has said positive things. She really wants to care for this baby. It's a labor and delivery setting on admission in very early labor. The screening tool, just for, again, as a sample within the scenario, is the 5 Ps. On the level of motivation to change is pretty moderate. We're right at like a 5, based on that sort of ruler, that I had sort of shared earlier, which is promising. So we're going to go through these steps. And again, I'm just sort of going to go read through this in a way that ideally sort of embodies, some of these values of MI and the brief intervention. So the first step is just building rapport and discussing that sort of confidentiality. So it might sound like this. We ask all labor and delivery patients questions about health and social issues, including substance use, so we can provide the best care to you and your baby. I see you completed this screening. So would it be okay to discuss your responses to the questions about substance use? I suppose. So one of the questions you said yes to, having alcohol or using some other drug while you were pregnant. Could you tell me a little bit more about that? I don't drink or smoke or use any hard drugs. I used oxycodone pretty often before I was pregnant, but then I tried to stop when I found out I was pregnant. Thank you for sharing that information with me. What made you decide to stop using when you found out you were pregnant? Mostly because I didn't want to do anything to hurt the baby. So it is important to you to have a healthy baby, and you didn't want to take any chances with the use of oxy. Yeah? What were your main reasons for starting to use an opioid later on in pregnancy? Mostly to help me sleep, and because I was starting to feel really stressed out and taking care of a new baby and everything. So the oxy seemed like a way to handle the stress, the sleep problems later on in pregnancy. How often have you been using in the last 2 to 3 months? About 2-3 times a week. So it is getting harder to sleep, and you are starting to worry about taking care of a new baby, and oxy seemed like an okay way to handle those issues. Is that right? Yes, exactly. I'd like to share with you a little information with you regarding opioid use in pregnancy. Is that okay? I guess so. So first, we know that opioid use can affect the growth of a baby in the womb, and that in turn can interfere with the growth of the baby later on and can lead to future problems with attention and learning. So it's good for our care team to be aware of opioid use in the past 2 to 3 months. What do you think about this information? Well, I didn't know this before I came in to deliver, so I really hope the baby is okay. I understand, and I want you to know that we will monitor your baby carefully and keep you informed throughout your labor and after your baby is born. I see that you plan to breastfeed your baby, is that right? Yes, definitely. What are your main reasons for choosing to breastfeed? Because I know it's good for the baby, and then I won't have to buy so much formula as well. Great reasons. And by the way, it's also good for your health. What do you know about opioids and breastfeeding? I thought it wouldn't be a big deal since I can wait a while after using it before feeding the baby. Is it okay to share some information about opioids and breastfeeding? Okay, I guess. We know exposure to opioids during pregnancy can lead to problems for the baby regarding feeding and sucking successfully when it comes to breastfeeding, in addition to dehydration, perhaps, and sleep problems. Do you have any questions or concerns regarding this information so far? I don't know. It doesn't seem like a big deal to use now and then. I have a couple of friends who used and breastfeed their babies and everything turned out okay. Our recommendation is to entirely avoid opioid use when you're breastfeeding, for your health as well as your baby. From our discussion, I'm hearing that you want to do everything you can to keep your baby safe and healthy. I'm curious, after learning this information about opioids, pregnancy, and breastfeeding, how willing are you to avoid oxy while you're breastfeeding and caring for your baby on a scale of, say, 0 to 10, where 0 being not willing at all and 10 being very willing to try? What number would you choose? Probably a 5. What made you choose a 5 and not a lower number, like maybe a 3 or a 4? Mostly because I want my baby to be safe and healthy. What might help you avoid oxy when you are breastfeeding or caring for your baby? I worry about how I'm going to handle the stress when I feel overwhelmed, so I guess I would need to find something else to help with that. Taking care of your health is also really important, so finding other ways to handle stress, especially with a new baby kiddo, right? So one idea, before you and your baby leave the hospital, the care team can continue this discussion and explore options to provide support for you and your baby when you go home. I work with the care team that could offer our support with breastfeeding, and there are other care team members that can connect you to community referrals and resources that may be helpful. These case managers work closely with patients to help identify the care and support that you and your baby may need after you are discharged from the hospital. Maybe this could help support your decision to cut back on oxy too. Sounds really good. So we've discussed reasons to avoid an opioid when you're breastfeeding and caring for your baby. It's important for you to breastfeed for your baby's health, and also very important to you for whatever you keep, so to keep your baby safe. You recognize that you need to take care of your own health too. So I will make sure that the care team on the postpartum unit continues this conversation with you and connects you with case managers who can work with you to come up with a plan and arrange support services for when you go home. They will also be able to share printed information with you about opioids and breastfeeding if you'd like it. How does this sound? Sounds good, thanks. I also want to let you know that for some families that have infants who have been exposed to substance before birth, CPS may enter our part of our care team to help assess needs and make referrals. Our goal is to help you and your baby have a healthy start together with the best resources and support in our community. We advocate for both of you. Sounds scary. Honestly, we work with a large care team, all the special roles in the care team for you and your infant together, and we truly want to support you and your baby. Okay, I understand. Okay, I really appreciate you talking with me about this. All right, so that again was just a sample script. There was different headings on it, but I felt like I just, it was best just to keep on going sort of through it for some continuity's sake. Again, a hypothetical. You all have a lot of wisdom and experience in this, right? But that sort of rounds out sort of the content for today. What questions do you have? What feedback do you have? Please feel free to unmute, type it in the chat, whatever works out.
Adam, thanks so much. I have less maybe of a question and more of a comment.
Okay.
I think what I appreciated about the points that you told us is that many of them are familiar to me in the setting of perinatal mental health. So like mood and anxiety disorders, I found a lot of the language that I typically use with depression and anxiety and pregnant and postpartum persons. And I think translating that same language to patients who are using substances can be really challenging for healthcare providers for a lot of reasons. And I think one of those reasons is that we really kind of hold closely to the tenet to do no harm. And I think for that reason, harm reduction can feel really uncomfortable for us because we tend to have very black and white thinking about what should and shouldn't happen for the safety of a patient and the baby. And so to me, I think what I did just in the last 30 minutes is make that connection with the language that I already know and use really often in my clinical practice. But I think it's just a matter of me bringing it to this new setting of substance use. And so I really appreciate both the language you gave us and then kind of helping us to make that connection.
Great. Thanks for that input, Amber. Let me check the chat here. Anything else? Any comments, any just questions, general inquiries?
I did really like your case study, and it always seems so beautiful and eloquent in those moments. And I'm just making a generalization. I think sometimes caregivers can feel overwhelmed to make it sound eloquent like that and very flowy and perfect. And I think we also have to remember that sometimes we're doing our very best in the moment. And I think our heart and our attitudes hopefully will shine through, and we can bridge some of that gap in those moments.
Yeah. Yeah. Karen, thanks so much for that comment. Right. I mean, a case study, like even like reciting it, it is, because I'm reading it, I'm whatnot, that's very different than in the moment, again, with other things happening. And I just really respect what you just said. And absolutely, that's, I suppose, like this conversation, it just like, I assume, like, just like it is with, anything, it's just one that, you feel out and you settle into like, what is like comfortable for me? What is like, where do I want to start from? Where do I want to be at when I start interacting in this conversation? And that should be the guiding force, right? One of the things that we coach on is you don't have to hit on all these bullets. You don't have to ask, 3 rulers in a row, these kind of things. It's just you being present in that moment and sort of with yourself. I know those are subjective things, but in some ways, like the spirit of MI, and that sort of sitting in sort of like compassion, acceptance, and evocation and partnership. Those are great places to start, and so I really respect what you just said, and thank you for sharing that. Yeah. All right, well, thank you all. I appreciate it. And I know Amber and Elena and the rest of the CPCQC team has all my information as well. So, and I'll make sure you have a copy of these slides and some of those other resources. So.
Thank you so much, Adam, for presenting. And I know for at least me, sometimes questions come up, but I'm too afraid to ask in front of everyone. So I really do encourage you, if you do have questions, to reach out to Adam and just kind of shop it with him and figure out kind of like what flows for you and what kind of scripting works for you when you might come into those situations. So I will be sending out a follow-up email with Adam's information as well as his slides. But right now we're going to transfer over to a presentation by Amber.
Just trying to share my screen. Did I do it correctly, Elena?
I think so. It's a little blurry for me. Is it blurry for everyone else? Yes. Okay, let me try sharing my screen really quick.
Where would I be without Elena, team? So while Elena is getting those slides up, I just wanted to say that at our launching call last month, we talked about how this year one of our goals is to prioritize some of the nuts and bolts of quality improvement. SUD at its core is a quality improvement project. And I think it can be really valuable for clinicians trying to do quality improvements to kind of get back to some of the basics and tools that we might not use in our everyday clinical lives, but can be very valuable to us when we're talking about quality improvement. So Elena is probably finding our correct slide. Yeah.
Is it? Oh, sorry, the correct slide, yes. I'm like, I swear I'm sharing it.
Teamwork, Elena. So I just wanted to do kind of a brief review. I think many of you were with us last month when we did our launching call. If you weren't, we have it recorded if you'd like to look at it. But I kind of wanted to review just some of the basics that we covered for QI last month, which is that suicide and unintended drug overdose are the leading causes of maternal mortality in Colorado. That's why this program is so important to us and why we focus a lot of our time and attention on it. 80% of those deaths are deemed preventable, and that's why this is such an emergent call to action and why we're devoting QI to it. And last week we covered sort of where QI came from, or last month we covered where QI came from and kind of the basics of what it gives for us. And what I love most about quality improvement is that it bridges research into clinical practice. I shared last month as a pragmatist, what I especially love about quality improvement is that they're really and truly just the direct action plans to address maternal mortality. And to me, I always like to feel like I'm both doing something and doing something that's worthwhile. And that's where kind of quality improvement speaks to me. So you can go to the next slide, Elena. I introduced this last time, and my teammates probably think that I cannot do a presentation without showing the model of improvement. So this is the Institute of Healthcare Improvement's model of improvement here on the left side of your screen. Last month, we talked about how the three kind of core questions give us a foundation for quality improvement. And then at the bottom, then there's where we kind of put our action plans into practice and do some experimentation on what works well at our sites. What I wanted to focus on today, just for a few minutes, is that top question for the model of improvement. And that question is, what is it that we're trying to accomplish? And I think one of the best ways to get to the core of what you're trying to accomplish is to first look at your mission and vision. And that can be your organization's mission and vision, your facility's mission and vision. And I know that some labor and delivery units actually have their own mission and vision for what they're doing. And I think getting back to the core of what is it, like why is your organization there and who are they serving, is a great starting point. And then moving from there is a great place to answer the question, what is it that we're trying to accomplish right here and now in order to address unintended suicide and drug overdoses. So go to the next slide, Elena. CPCQC is willing to be a guinea pig for this for you. So I've put on this slide what our organizational mission and vision are. I'm not going to read them to you, but I think that for me, at least, when I think about adding new things to my plate, I often come back to what our mission and vision is and see how it fits into that. And then from there, that's how we choose the projects that we work on, the teams that we partner with. I've created an aim statement here at the bottom, and it's actually something that our team is actively working on. And so our statement that we're working on is that we want to increase hospital team engagement from 40% to 60% of teams that are attending our monthly coaching calls. And we want to do this by the end of December of this year. So you can go to the next slide, Elena. And I told you that I'm a pragmatist. I only like to do things that are worth my time and effort. And so you might ask, why our aim state? Like, why do we need to be so formal about this, right? Like, we know what our goal here is. It's to give better screening and clinical care to pregnant and postpartum persons. But can't we just get to work? Like, why do I have to think about it in this way? And I think, one of the things that research shows us is that teams who develop really good aim statements perform better. And good aim statements really capture the voice of the customer, who it is that we're trying to serve. I like it because aims are a really great way to go back and focus your time, your resources, and your attention. No one wants to be chasing a goal that doesn't make sense. It isn't worth your time and effort. So we can go to the next slide, Elena. The Institute of Healthcare Improvement uses kind of a 4-step process for making an aim statement. They really encourage us to use these 4 questions to kind of get at the core of what's worth our time and effort and what's really going to serve the people that we're intending to serve. That's by asking, what is it that we intend to accomplish? For whom do we intend to accomplish it for? And then how much do we intend to improve it, and by when? And this takes some practice. I know that many of you are familiar with SMART goals. They're specific, measurable, achievable, and so on. This is sort of a quality improvements version of that. And it gives you a really great structure to make sure that you're making a goal that is, again, achievable, measurable, and something that's focused on the population in the area that you want to focus. So if Elena, you go to the next slide again, I kind of made it vulnerable to CPCQC and this project specifically, and I made kind of just a generic aim statement. If you wanted to hit all 4 of those questions, it could look like this. We are going to improve the delivery of appropriate clinical care. And this is for all of the patients who screen positive for substance use. We want to increase it from 25 to 50%, and our goal is to do that by June of 2023. So again, this might not be your aim statement, but this is sort of a general aim statement of a lot of the things that we're trying to accomplish within COAIM SUD. Elena, you want to go to the next slide? I really want our teams to come up with at least one aim statement. And I hesitate to give you all homework because I know that you have a lot on your plate. But again, I think there's a lot of value to us really setting intentions, voicing those intentions, and then allowing your team to kind of rally around what that is. Because I think if your team doesn't really know what it is you're trying to accomplish, then it's really challenging to work in unison and to conserve your time and resources. I'm gonna put, unless Elena has already do it, we're gonna put a Jamboard in the chat here. If you're at a computer that you can access this Jamboard, I encourage you to click on it for me. And I would love over the next month, if you guys had a second to come up with an aim statement for your teams. And that can be over the next 3 months, 6 months, year. I'm not gonna constrain you for what that looks like. But in this slide here, I've listed some of the areas that you might want to consider. Maybe you want an aim statement around your screening rates at your facility, or a specific clinical care practice like a discharge, a postpartum visit that's scheduled at discharge. That's something that your team needs to work on. Maybe you want to make an aim statement about creating an outpatient referral network for your hospital. You could make an aim statement about how it is that you're going to engage the nurses on your unit. And so really the field here is broad with what you could do with this. I'm going to leave it up here at least for a few minutes. I gave the example that we talked about earlier for one of CPCQC's or our quality improvement aim statements for what we're trying to achieve. There's no wrong answer to this. So I really encourage you to just put something on paper. If you put it on paper here for us, our team would love to give you feedback on it. And it also helps us in our coaching to focus on what is it truly that you need. We don't want to be giving you resources and coaching on things that your team isn't actually working on, and it's not the focus of your time and effort. So I think it's kind of mutually beneficial for us to know what it is your team is aiming for and how it is that we can support you. If it's possible, maybe attach it to your name if you're comfortable doing that. We'll provide feedback either way on this Jamboard. But if you're willing to go ahead and identify yourselves, that might help us to be able to give more targeted feedback. So some people are already adding to it. I love this. We're gonna share this Jamboard out in our follow-up email. So if you need access to it longer term, or you want to take it back to your teams and get a better idea of what their aims are, you can always come back to this Jamboard. We are going to use these aims in our next month's coaching call as we're talking more specifically about, okay, now that we've created an aim, how do we actually execute on achieving that aim? And we're going to talk about sort of furthering tools. This is sort of the building blocks, and we're going to escalate during each monthly session on building upon the foundation that we have here. So continue to use it. I'm hoping that you can multitask a little bit because I'm going to go to the next slide. And I just wanted to touch on multidisciplinary work groups. I know our team keeps bringing this up to you. We keep asking you, do you have a multidisciplinary work group? What resources do you need for it? And I wanted to get back to the core of why it is that we're asking that so often of you. CPCQC has made a very specific goal around multidisciplinary work groups, and I have it written out here for you so you can see exactly what it is that we're aiming for. By the end of this year, we want at least 30% of our hospitals in COAIM SUD to have an active multidisciplinary work group that meets with both inpatient and outpatient providers. We want them to meet regularly. That schedule could be different for every facility, but a regular meeting schedule that's helping to support your initiative at your facility. And the reason that we want that is because this is one of our keys to making your programming sustainable. CPCQC is maybe not always going to be here to hold your hand and to support you in a learning collaborative, but the people that are going to be there consistently are the people who work and are invested in your hospital and your site and in your community. And this is one of the best ways that we can help support you in your way. So that's the background and why it is that we're talking about multidisciplinary work groups so often this year. And I wanted to remind you that we've developed some resources to help you along that journey. So we have a visual that you guys have probably seen. It's like a triple Venn diagram of the types of people that we recommend having on your work group. We also have a list of suggested workflows. So if you're thinking, okay, I have people in mind, but what is it that this group is actually going to do and how can we make their time useful? We have some ideas for workflows for you. We also recently created a recruitment letter. So especially if you have outpatient contacts, and you don't actually have a warm handoff for those people, like a connection, you want to just reach out, kind of a cold call to them. We have a template for a recruitment letter that kind of explains what it is that you're asking for them. We'd be happy to share that with you if you want that. And then finally, if you do have a multidisciplinary work group or you're getting ready to launch your multidisciplinary work group, our team would be happy to see if we could attend with you, at least for a meeting or so, just to kind of get the foundation of what the goal of this group is and to set you on your way. So again, if you have a group or you're getting ready to launch a group and you would like us to at least initially have some involvement with helping you along the way, we would be happy to do that. So reach out to us. And Elena, I think that might be it for my slides.
Great. Thank you so much, Amber. Does anyone have any quick questions before we move on? And you're welcome to chat them in or come off mute.
I'm really thankful you guys are using the Jamboard. It makes my heart happy. Thanks for participating. Again, if you don't want to finish it today, we'll share it out. You can continue working on it, but know that we are going to revisit it next month. And so if you don't want to be embarrassed by not having an aim statement, then we will peer pressure you into doing that.
It's that like fear that just CPC is going to come after you. So we're going to move on and I'm going to pass it over to Katie, and Katie, I'll share the slides for you. But Katie just wants to briefly talk to you about this new initiative we're starting.
Yes, so I touched on this a little bit at our kickoff call in February, but I know a lot of folks weren't there. So we want to talk about this new opportunity that you all have access to. You can go to the next slide. So a lot of you might be familiar with the Colorado Moms Initiative. That is the initiative that is getting you all take home naloxone on L&D units. I know a while ago, we started connecting folks to who were part of SUD who were interested in naloxone dispensation to this team at Colorado Moms, and that's really taken off, and we're super happy that so many of you are working with the Colorado Moms Initiative to be dispensing take-home naloxone, and of course that is one of the measures of this AIM bundle that we're collecting data for SUD. So the next slide is a new initiative. So you know about Colorado Moms, you might not know like what it's called, but it's the Naloxone Project. There's a new initiative that we're very excited to be able to offer. So through funding from the Behavioral Health Administration, CPCQC has a new program in partnership with Seder Opioid Consultants that is called Moms Plus. And so what Moms Plus is helping L&D units not only figure out all of the nuts and bolts that go into doing take-home naloxone, such as, the sort of work that you're doing with the Moms Initiative, or you might be doing with the Moms Initiative, but also take it one step further and make sure that your hospital has the capability to initiate medication for opioid use disorder for eligible patients, and then make sure that patient is then connected to continuing outpatient care. So the team of folks on the Moms Plus team, one of them is here. It's Dr. Kaylin Klee. She is our Colorado expert on perinatal SUD. So we're very happy that she's part of this work. And then also Rachel Duncan, who is a pharmacist and is also a leader on this work. And they will really work hand in hand with your teams to supercharge the work that you're already doing through SUD. So essentially what they'll do is is work really closely with your hospital and with all sorts of stakeholders that you need to bring to the table in your hospital to figure out what is needed to really have a comprehensive care and referral protocol for patients on L&D who screen positive for substance use disorder. So making sure that you're able to connect them to medication for opioid use disorder, and you have the resources internally and via referrals to do so and to get them started. Making sure that patients are getting sent home with take-home naloxone, looking at your order sets, looking at all of your workflow processes in a way that is a much deeper dive than like the way that you tend to work with CPCQC. So because we realize this is a deeper dive, there's actually monetary support for your hospitals to do it. There's $2,000 for each hospital who signs up for this and goes through this process. And again, it's super complementary to what you're already doing. It will just, again, like supercharge what you're doing and really like work hand in hand with you to figure out like where are the areas that we still need support on to get our SUD care for perinatal patients to the best place it can be. And this team can help you do that. So next slide, just for a timeline, we are holding some info sessions in the next couple of weeks. Honestly, like if you're listening to this right now, you don't necessarily need to attend an information session, but if there are other folks at your hospital you'd want to get on board, certainly it would be good to send them to those info sessions. And then April 11th will be the deadline for hospitals submitting formal interest in becoming a pilot site for this new program. And then we'll select up to 10 pilot sites open to any Colorado birthing hospital. And then we'll sort of take it from there. And the Moms Plus team will work with your hospital. So next slide. So the idea being that like from April to June, there'll be surveys and sort of needs assessments that the Moms Plus team does with your hospital. And then virtual meetings in June, site visits July, August, September, and then helping your team implement in the fall. So we're very, very excited about this. Is there any slide? Is there another slide?
No.
Okay, that's fine. So we're super interested or excited about this. So like Elena said in the chat, you can reach out to info@cpcqc.org and we'll connect you with the Moms Plus team that is running this. And also if you're like, I'm not sure, we're happy to answer any questions you have. And yeah, Kaylin, did I miss anything?
No, I think that was a great intro. I think for a lot of hospitals, if you've been wondering, how do we actually take the step to not only screening, providing resources, but actually initiating medication in the hospital and connecting people to treatment services, this is the program for you. Because it really, I feel like for a lot of individual clinicians, for hospital systems, like just getting that first step or that connecting that next step of starting treatment in the hospital has been challenging, right? For small hospitals and big, huge hospital systems alike. And we now have, I think, enough experience, both locally and nationally, to really help folks get this off the ground. I am happy to answer any questions, but I also don't want to take up too much time. So if folks are able to attend any of the meetings, if you're like, I just want to learn a little bit more, attending any of the info sessions is not a commitment. We will not hound you. This is an invitation, right? And so, yeah, I hope that there's, I've talked with a few hospitals already that I'm like, you guys are doing this. This is a way for us just to like really protect some time to help support you as you're already working on updating order sets, thinking about how to best treat pain in the postpartum period for people with substance use disorders, right? If you're already kind of doing some of that work, this is this is a way to really have some structure and a little bit of financial support, but a lot of people support to really help you make your dreams a reality.
So inspirational, Dr. Klee.
It's like so fun. I mean, I think that's the other thing is I'm like, if you've been just like dipping your toe or getting ready, I think this is such special work that once you get going, it really takes on a momentum of its own. And it's really exciting to see. If you're here on this meeting, you already have this fire in your belly. And so this would be a way to really help bring the team around you. And it's awesome work. So come on in.
And you go to work with Dr. Klee, which is, if you get a little snippet of her time, it's
no,
gold.
I'm like, maybe that's a negative. If those of you
Oh,
who are like
please.
sick of
Oh
me
my
by this
goodness,
time.
Kaylin.
Like, maybe we should like, I'm like, I promise I won't make too many. I don't know. I'm okay with this. Is so much fun to share, right? Because I get to do this work every day, and it is so special. And so I'm excited to be able to help the folks who really are ready to take this next step. Join in.
Awesome. Well, thank you. Yeah, so I put in the chat our email if you don't know it. So feel free to reach out to us at CPCQC if you're interested in joining, and we'll connect you. But just to wrap up, I'm going to launch our evaluation poll. It's the same poll as we do every time. So if you could complete that, that would be great. Then I have two quick reminders. One, I sent out this past week, the registered nurse culture survey. This survey is the same survey that I sent out to you for my capstone project last March, and we're doing a second round of it. So if you could distribute that to your registered nurses in your unit, that would be great. It should take 2 to 3 minutes. It's really short. So that would be really helpful to us if you could complete that and distribute it. And then the second reminder is just that our April coaching call is April 13th. And I sent out calendar invites this year. So hopefully they're all on your calendar, so you don't have to even register. But it is coming up in almost exactly a month from now. So just those two quick reminders. And then just to complete this coaching call evaluation, if you get a second. And I hope you all have a great rest of your day.